In this segment, imaging in the management of rheumatoid arthritis, I'd like to talk about a subject I think would have been unheard of just a few years ago. How the use of imaging, in particular in-office MRI, is helping us not only make an early diagnosis, but in managing our patients and making the correct therapeutic choices. If we go back to the ACR recommendation that came out in 2002, the recommendation was that early aggressive treatment of RA makes a difference. Successful treatment to limit joint damage and functional loss requires early diagnosis and timely initiation of disease-modifying agents. The goal of treatment is to arrest the disease and achieve remission. In order for us to achieve these goals, we need to be able to make an early diagnosis. And unfortunately, to this point in time, the traditional form of X-ray does not allow for an early diagnosis. We can make an early diagnosis and establish treatment. I truly believe we can shift the paradigm to a more effective outcome in the era of rheumatoid arthritis. And in fact, if you look at studies that have basically been repetitively published, and this one is from Lindquist, we see that in fact 75% of all damage that occurs in the joints of patients with rheumatoid arthritis occurs in the first 5 years. In many cases, these patients have not been diagnosed or treated early enough because the manifestations of the disease was not apparent or not obvious enough. If you look at the patient's progression, the progression occurs predominantly in the first 5 years. This does not mean that progression does not continue to occur, but certainly it does suggest to us that an early diagnosis and an adjustment in therapy is critical in the management of rheumatoid arthritis. The new world evidence that MRI and other technologies have brought us is to recognize that signs and symptoms do not always correlate well with structural damage. And in fact, if you look at this study that was published in the 80s, we see that in fact the total radiographic score does not correlate at all well with either swelling or tenderness of the joints. And in fact, if you look at more recent work, and this is from the ATTRACT study, which you're all very familiar with, the pivotal study for infliximab, we look at the placebo group and we can see evidence of patients who appear to be ACR20 responders in the placebo group on methotrexate only, having a progression of their erosions despite the fact that they clinically appear to be responding. And this is certainly no different than for those of us from the pre-biological era who treated our patients for many years with our DMARD of choice, usually methotrexate. We thought we were doing a good job, usually in conjunction with corticosteroids added on top of the DMARD. But at the end of the day, when we looked at our patients' radiographic findings, we were not surprised in many cases, or we were surprised, but not really unusually surprised to see a progression of radiographic damage, despite the fact that our patients had apparently clinically been doing what we considered well. And in fact, the importance of this is not just in terms of the patient's symptoms, but we see how the structural damage that is inversely proportionate to the signs and symptoms in many cases actually may in turn be a predictive measure as to who is going to become more disabled as the disease progresses. So with the advent of the biologicals, we've really shifted our therapeutic strategy. In the past, the importance when a patient came into our office was to control their pain and to obviously limit the toxicity of the drug while doing so. At the end of the day, hoping to be able to keep the patient functional. I think now we recognize that while that is still obviously important, it's just as important to minimize joint destruction. And to do that, we have to essentially initiate our therapy in an early fashion before irreversible damage occurs. Now, as part and parcel of helping our patients, I think we also need to look at the cost of what we're doing. Ultimately, the question as to the cost of therapy and the cost of imaging needs to be measured against the cost of taking care of a patient who has been unable to sustain themselves in their normal environment in society, becomes a burden to their family, and essentially the cost of maintaining that patient definitely needs to be measured against the benefit and the cost of the therapy that we are providing. Prior to the advent of the biologicals, the demand for joint imaging was modest at best. I think in most cases it was considered that X-rays were more than sufficient in making a diagnosis. Most studies, if not all studies, were to some extent designed around an endpoint where we measured erosive changes by X-ray. And the thought process has been and still is to a large extent, why pay more for MRI? What information or evidence is MRI going to provide us that X-rays cannot? However, with the advent of structure-modifying therapy, the biologics, I think imaging has become a far more essential component of the therapy that we are utilizing. We need to now consider the pros and cons of various imaging techniques, whether that be X-ray, CT scan, MRI, or ultrasound. There is no question that for many years radiography had a role to play, but I think there is an absolute awareness that there are marked technical limitations in the use of radiography. Certainly, in reality to maybe the perception, X-rays are very insensitive for bone erosions. The X-ray lucency reflects primarily cortical bone loss, and the intramedullary component of erosions are extremely poorly depicted. Projectional superimposition very often obscures the non-tangential erosions. X-rays are very inaccurate in terms of measuring cartilage loss. The standard way in which we measure cartilage loss by virtue of joint space narrowing is an indirect method. If we have joint flexion, subluxation of joints, or technical problems such as change in the beam centering, these can all simulate joint space narrowing, and joint laxity can undermine joint space narrowing. So as a marker of cartilage loss, this is a very poor measurement, even though for many years it has been a standard measurement. Furthermore, the changes that occur in radiography are slow. Most studies that are designed where radiography is an endpoint are a minimum of 6 months and usually 12 months. The use of placebo control is no longer ethical, which means we need to have faster outcomes, better measurements, and shorter studies. I think if we can do that, the studies that have become almost astronomical in their cost can be reduced in magnitude, and the outcomes can be much more valuable and usable in terms of measuring the benefit of the therapies. Certainly, the ability to measure synovium, marrow, tendons, and cartilage is part and parcel of measuring the outcomes in rheumatoid arthritis. So with that in mind, we look at our standard radiograph, X-ray of a hand, which I think most of us would consider a normal X-ray, and simultaneously we look at that same hand at the same time with a patient with rheumatoid arthritis, and the erosions are clearly visible to even the most inexperienced eye. Now, MRI is not something that was just discovered. In fact, believe it or not, it's actually over 50 years old in technology. It was in 1946 that Bloch and Purcell described the MR phenomena. They subsequently won a Nobel Prize for that in 1952. And we see that over the next 50 years, there's been multiple articles describing the use and value of MRI in most areas of medicine. To a less extent, however, in areas of rheumatology. But having said that, it's actually interesting to note that in the literature there are multiple articles on the value of MRI. And in terms of the comparison of MRI to X-ray, we see that these articles that I have listed here all reflect that MRI is at least twice as sensitive as X-ray for the measurement of erosions alone. The fundamental advantages of MRI over radiology in rheumatoid arthritis are many. The MRI essentially is a tomographic view that looks at the broad tissue contrast in a digital format. It visualizes not just the cortical bone, but it's visualizing the marrow, the synovium, the articular cartilage, the ligaments, and the tendons. By virtue of its digital image format, we're able to send or transmit the images to a centralized reader. We're able to control the measurement and the standardization of the findings in a far more acceptable fashion than we were with radiology. I think that the speed in which MRI is capable of detecting changes in the erosions and synovitis, both in early diagnosis at the time of onset of the disease and following therapy, makes it a far more superior tool to the standard form of radiography. Obviously, radiography was much more available in less developed countries. It is going to still be a valuable tool for the diagnosis and management of patients, but as a state-of-the-art comparison, there really is very little comparison. MRI has superior sensitivity to all forms of bone damage. If you look at this particular study from John Cruz and Oren Trom from Los Angeles, they looked at a comparison between MRI and X-ray findings in the wrist and MCP joints of patients with inflammatory arthritis, and their findings reflected that MRI identified erosions in 95% of patients with the diagnosis of inflammatory arthritis in 78% body locations, and this was almost twice as many erosions identified as in standard radiography, where only 59% of patients and 39% of body locations were identified as having erosions. 41% of body locations showed MRI imaging evidence of erosions when the X-rays were negative. So in almost twice as many situations, the X-rays were negative compared to the MRI findings, and that's a very significant comparison. I think part of the reason why we've been a little slow in rheumatology to jump on the value of MRI is because the conventional MRI was certainly not user-friendly and is not user-friendly for the patient with rheumatoid arthritis. It was introduced in the early 1980s, and truthfully, since that time, there's always been an extreme squeeze on most MRI facilities to get patients into the MRI and obviously make a diagnosis for the relevant specialty. And rheumatoid arthritis, as usual, has taken a back seat. But in addition, it's very uncomfortable for a patient with rheumatoid arthritis to put their arms in a so-called swimmer's position inside the conventional MRI, and many patients have not been able to tolerate it. This is in addition to obviously being claustrophobic, and finally, I think, and maybe most pertinently, the cost of one of the conventional MRI units in a rheumatology environment is almost cost prohibitive to set it up. So I think we probably lag behind for many of those reasons, but more recently we've had the advent of the so-called low-field MRI. This is a 0.2 Tesla strength magnet as opposed to 1.5 or in some cases a 0.75 large magnet, which was the conventional MRI. And if you look at this illustration and you compare standard very good X-ray to a low-field MRI, I think it's fairly obvious to see the significant erosion that the MRI is illustrating in absence of any erosion being noted in comparison on X-ray. I'd like to have us look at this slide. This is of a unit that is essentially a hologic extremity MRI. This would be installed in a physician's office, a rheumatologist in this case. And this MRI is very capable of measuring changes very much in the same capacity as a large MRI of the foot and ankle, the knee, the hand, the wrist, and the elbow. It's a little more difficult to do the shoulders and the hips, but nevertheless, in some cases, could be adjusted to do so. This is actually an illustration taken from my own office in which we see a patient very comfortably lying and having her hand measured. The average length of time for this procedure would be approximately 35 minutes per extremity. A key to getting good images is to make the patient relaxed and comfortable. As you see, there's no claustrophobic effect. There's nothing at all that the patient needs to be afraid of, but they do need to keep still. We do use a foam pad to stabilize their extremity, which allows for us to be consistent in being able to repeat the position from image to image. As you look at this picture, there is no specific shielding that is required in this room. This was, in fact, an examining room in my office, which we converted into the MRI room, so to speak. And I think this shows you the ease in which you can essentially assemble an extremity MRI as opposed to the complexity of setting up a large MRI in your office. Orthopedic surgeons may prefer to have one of the bigger extremity MRIs because they do like to do shoulders and hips to a larger extent than we do. If you look at studies that have been performed, and the reason I'm showing you the next couple of studies is because there's been a lot of controversy as to whether the small magnet extremity MRI can stand up in comparison to the standard large magnet MRI. And this is a study that was published in AJR in 2004 by Teoli's group, in which they compared a conventional high-strength MRI of 1.5 Tesla strength to a low-field strength dedicated extremity MRI of 0.2 Tesla strength. At the same time, they also compared X-rays. The studies were interpreted by two blinded radiologists who did not know which MRI had been utilized to measure the extremities, and the measurements utilized the Sharp-Gannon scoring system and measured erosions, synovitis, and joint space narrowing. And if we look at the comparison between the technologies with regards to erosion, synovitis, and joint space narrowing, the comparison between the two MRIs, the low field and the high field, was extremely compatible. There was very little difference in the observer measurements on any of those parameters, and obviously both MRIs were far superior to the measurement by virtue of X-ray alone. Egberg's group in Copenhagen did a similar study in which they measured a low-field dedicated extremity MRI in the wrist and fingers in patients with rheumatoid arthritis and compared it against a high-field MRI and standard X-rays. They had a slightly larger patient population, and their evaluation was according to the OMERACT interpretation of rheumatoid arthritis measurements. And they measured once more erosions, synovitis, and bone marrow edema. And we see that except for bone marrow edema in terms of sensitivity, the comparison once more between the high field MRI and the low field MRI had a very high degree of specificity, sensitivity, and accuracy, and far superior to X-ray in all cases. So the conclusion in multiple patient studies is that low-cost, patient-compliant, low-field dedicated extremity MRI provides similar information on bone erosions and synovitis as expensive high-field MRI units. And I think we need to come to terms with the fact that this is, in fact, a proven fact. One of the other questions that I'm often asked is, are MRI erosions real? Frustrating question in many cases. I think the kind of question Christopher Columbus was faced with when they asked him why he thought the world was round. Because in fact, if you see erosions in a patient who's got rheumatoid arthritis, I think it's fair enough to believe that they are part and parcel of the disease. Nevertheless, erosions have been correlated both with the MRI and then with arthroscopic evaluations, CT evaluations, and ultrasound evaluations. Now, there are false positives that can occur, and you certainly can get holes in the bone from conditions or reasons other than rheumatoid arthritis. For example, tumors, ganglia, screw holes, and postoperative defects are all capable of causing a hole in the bone. And so I think, like anything else, whatever test it is that you may be doing, whether it's a sedimentation rate, a C-reactive protein, or an MRI, we need to take the whole picture into context when we decide whether MRI erosions are real or not. While I was developing this lecture, and as recently as April of this year, and I refer you to this article in A&R by Esther Jimenez-Boj and her group of collaborators at the University of Vienna in Austria. And this article came out, as I said, while I was putting this talk together. And I think it's one of the most exciting articles that have been published on MRI in really recent memory and in my experience. And what they did was that they compared the findings on MRI in patients who were going for hand surgery to have small joints in their hands replaced with a Swanson prosthesis because of rheumatoid arthritis. And what they did was they did an MRI on these patients' hands a day before surgery, documented, as you see in illustration A and B over here, a T1 in A and a stir image in B. They documented the presence of an erosion and bone marrow edema on the MRI. And then when they went to surgery, they removed the small joint, and what they did was they actually correlated the exact location on the MRI to the pathology specimen. They then went and looked and evaluated how the pathology correlated with the MRI findings. And what you see in illustration C and D, in both being the same location, one being a small field and the other one being a high field evaluation, is that you see inflammatory infiltrate and involvement of a small blood vessel in the bone marrow corresponding to where we see the osteitis or bone marrow edema on the stir image. So what we're actually being able to validate over here is that this change in bone marrow that we're seeing on the MRI, on the stir image in particular, correlates to the presence of inflammation in the bone marrow. You look at this higher power field over here, a more magnified view, once more we see on the stir image this significant osteitis of the bone marrow. This is this white infiltrate that you see in the normal marrow. What it is it's the inflammatory water-based infiltrate that's replacing the normal fat content of the marrow. And if you look at that in terms of comparing it to the histology, you will see that depending on where the biopsy was taken and where the MRI image is, you see that the amount of inflammation is directly proportionate to the infiltrate or the intensity of the abnormality on the stir image. So you're actually seeing how we're now able to understand that the findings we're seeing on MRI absolutely correlate to inflammation, not only in the synovium, but actually in the bone marrow. And it certainly brings up the thought process as to where is the inflammation really developing from. I think for many years we've thought that rheumatoid arthritis was essentially a synovium-driven disease, a disease of synovitis. We now can certainly start focusing on the fact that there is definite involvement of the bone marrow, and maybe this explains why some of our therapies are working in the ways that they are working. But from my perspective today, it's to illustrate the value and the importance of MRI in management of rheumatoid arthritis. And in fact, if you go back and you look at studies that have been done, we see how there actually is an ability to predict functional outcomes based on MRI of the wrist. And Benson was the first individual who really described this, and he showed how osteitis predicts functional disability at 6 years, far more accurately and predictively than pretty much a DAS score or the CRP score alone. And if you look at these next few illustrations, you can see from left to right, as you go from baseline to 3 months to 6 months, how rapidly osteitis can progress from essentially a very subliminal lesion to a full-blown erosion. And similarly, we can see that if you treat osteitis aggressively initially, you can actually see the osteitis reversing before an erosion develops. And with those previous slides that I showed you, it's now not that difficult to understand how by turning off the inflammation and reversing the inflammation, if we get to the disease soon enough, we can certainly prevent erosions from developing. And here we see how you can actually see erosions resolving over a 24-month period. And note that the x-rays are certainly not discernibly different between baseline and 24 months, but if you look at your your STIR images, you can see a significant resolution of erosions over a 24-month period with therapy. So certainly there is a point of no return. We don't know where that is, but I think by this illustration, you can understand why the use of MRI is so helpful, not only in the diagnosis, but in making sure that you've chosen the correct therapy. Because the patient's clinical response is certainly, as we know from the past, not enough for you to determine whether your therapy is effective to the level that you want it to be or not. Don't forget that the use of MRI is also valuable in looking at tendons, tenosynovitis, in diseases not just rheumatoid arthritis, but certainly SLE, osteoarthritis, psoriatic arthritis, where you'll see tendonitis and enthesopathies. At times, the use of an MRI can be very valuable in documenting the degree of inflammation and joint involvement. So when you look at where my enthusiasm and excitement comes from, and certainly not mine alone, but I think that mine basically based on what so many other people have now been able to publish and demonstrate. MRI is really an ideal tool for rheumatoid arthritis, especially extremity MRI. It focuses on the study of small joints, primarily the MCP, MTP, and wrists. We get a very nice high-resolution study. And the slices are, in fact, thinner than on conventional MRI. We're talking about slices that are 0.6 millimeters thick. They're 1 millimeter resolution in plane. And very pertinently, we're actually seeing contiguous studies without gaps, as opposed to the conventional 0.5 millimeter gap that you'll see in your larger MRIs. And that means that we may, in fact, be at times more capable of seeing osteitis or erosions in some of these extremity MRIs than one could potentially have seen in the larger MRIs. Like everything, there's advantages and disadvantages. We've spoken about some of the advantages. The disadvantage of a smaller field of view, at times that may be an issue if you really want to see more than one area, and the solution is to do another image, just positioning it differently. There may be slightly longer imaging time in some of the extremities required, and there are a reduced number of possible imaging techniques with extremity MRI. You have to recognize it is what it is, and it's providing you certain value, but it's not ever going to be as versatile as a large MRI. Remember, from your office perspective, very little is required other than the space. It has to be relatively noise-free. You can't put it next to an environment where there's too much background noise on the other side, as this will interfere with the measurement. And from a patient's perspective, they love coming into the office. Patients who've been for a conventional MRI on their knee and then come in to have an extremity MRI in my office, they can't believe the simplicity of coming in, getting it done, reading a book while their knee is being done, not having to wear headphones and have a jackhammer pounding their brain. So I think extremity MRI has definite values. I've illustrated here a comparison between some of the different extremity scanners on the market. That's for you to slice and dice and take out whatever information you would like. I think all of these machines have advantages and disadvantages. The facility that you have is going to dictate to some extent the need, the cost, the amount you want to spend, and ultimately the resolution are all issues that you should go into detail when you decide that you would like to potentially acquire one. Remember, rheumatologist needs are definitely different from radiologist needs. Radiologists need to look at head, spine, abdomen, and not just the extremities. We are concentrating on looking at the extremities, and for that purpose, I think we definitely can say that extremity MRI is very specialty specific in being something that can help us, and very disease specific in being so valuable for the management of rheumatoid arthritis, where extremity MRI is, I think, more than significant. The clinical indications for MRI, and this is actually based on the ACR Extremity MRI Task Force publication, I think definitely for early objective assessment. Treatment based on MRI findings. Obviously, there's a significant comfort in having an MRI that you can utilize when you're making a decision to treat your patients early. We know that our treatments have potential side effects, and I think the value of knowing that there is actually evidence based on your therapeutic choice is significant. Once you've made your diagnosis and established treatment, the ability to follow the outcomes of your choices and monitoring your treatment and adjusting your treatment is huge. Because I think in many cases we just blindly treat our patients not really knowing what the drugs are doing. The ability to show that your treatment has worked, reversibility of osteitis or erosions, is very, very significant. Your patients, by the way, will have a very significantly improved compliance when you show them why they've been treated, why they've been coming for therapy, and why they should continue coming with therapy, very similar to the oncology model. And while there is no current consensus regarding when MRI should be ordered for the management of RA, I believe that's just a matter of the time that we're at with this particular science. You obviously need to make your own decisions where you'd like to utilize it, but ultimately a consensus usually takes time and usually occurs after many years of experience. The implications for your practice: obviously make sure that you understand the coding that's involved for MRI, and that's listed over there. Most insurances will pay for extremity MRI if you utilize the appropriate ICD-9 codes, but certainly not all do. And unfortunately, some of the insurance companies out there have jumped on the ACR white paper and utilized it to deny payment. You need to deal with this on a case-by-case basis, but be aware of it, because you don't want to get into a situation where you find yourself in a negative situation because you didn't get pre-approval or certainly research whether reimbursement was available or not. I've listed the ICD-9 codes there that are Medicare reimbursable. The question as to whether you should do your own interpretation or whether you should send studies to a radiologist, that's a personal choice. I personally send my studies to a radiologist. I believe a radiologist is more suited to read MRIs. I know we used to read our x-rays all the time and still do, but I think the way in which MRIs are needed to be read, the time that is involved with each slice in each joint, I think makes it more practical for someone who's doing that all day long to be the individual to read it. Once more, it's personal, your choice. The industry standard is to use a DICOM format, and we simply transmit our images electronically via the internet to the radiologist and get our interpretations back usually within 20 or 4 hours. Standard security that you would utilize on all forms of internet transmission are just the standard. I think I need to mention a few words on ultrasound and rheumatoid arthritis. Certainly, I think if you were in Europe, the majority of people there would be talking more about ultrasound than MRI. I think that that's A, a cost issue, and B, a time issue. From my perspective, I think ultrasound has been shown in the literature to be less sensitive with regards to erosions than with MRI. It's certainly less expensive. It's portable, and you get your results immediately, so it's real time. It is operator dependent, so you do need to have a good ultrasound operator, but obviously this is not something that is too difficult to set up, as we see with all the office-based ultrasounds for other specialties. It's somewhat difficult at times to standardize the ultrasound findings because of operator variability. And so the production of localization of dimensional measurements sometimes is a problem. And certainly longitudinal examinations in multi-center studies is difficult with ultrasound. The Doppler evaluation of synovitis may be useful for quantifying changes in inflammation. But I think, as this illustration reflects, the MRI is a far, far better measurement tool for erosions than ultrasound. When it comes to synovitis, the synovitis is probably equally measurable or even better with the ultrasound. And in both cases, the X-ray technology falls way behind both MRI and ultrasound. So in summary, joint damage occurs early in the course of rheumatoid arthritis, and therefore our choice of imaging is critical. MRI and musculoskeletal ultrasound are more sensitive than X-ray for detecting erosions and synovitis, and both the MRI and ultrasound have value as imaging tools in rheumatoid arthritis. I think At the end of the day, low-field MRI may be a cost-effective and patient-friendly imaging technique in the rheumatology office. Obviously, more research is needed into the utility of low-field MRI, but we already have a number of studies out there that reflect the sensitivity, specificity, and predictive value of MRI. So I think at a certain point in time, we need to come to terms with the reality that this exists. But certainly, more research is needed in the value of MRI in driving treatment decisions. The validation issue is really not an issue. We just saw that article comparing the MRI findings to bone marrow findings. Resnick is doing an MRI study from patients with rheumatoid arthritis at autopsy. There is still positioning reproducibility, which is difficult from center to center. We've obviously got to train readers to read in a consistent fashion. And I think probably a relatively small beta study to work out bugs is in order, and a large multi-center RCT in early RA under an IND working with the FDA would be the most desirable. I'd like to leave you with the thought that for many years, osteoporosis was an orphan disease that, to a large extent, was ignored until the advent of bone density. With the advent of bone density, we were able to suddenly recognize the existence in so many people of osteopenia and osteoporosis. The diagnosis increased the awareness not only for us as physicians, but for our patients. And as a result of that, their compliance improved. And as a result of the combination of that, we came up with more therapies that we've basically now added to the armamentarium of treating osteoporosis. And we've been able to utilize the bone density tool to adjust our therapies, to add to our therapies, and I think to make a significant dent in the problem of osteoporosis. Well, I think if you use that exact paradigm and you put MRI into the place of bone density and rheumatoid arthritis in the place of osteoporosis, we'll see that by virtue of MRI helping us with an earlier diagnosis, increasing awareness for both physician and patients, making us aware of the adjustments and changes that different therapies can affect on the disease, that the paradigm will be very similar, and that maybe 10 years from now we will just recognize that MRI imaging is part and parcel of the management of rheumatoid arthritis. I hope some of these facts, some of these possibly controversial statements, some of these personal beliefs will be provocative enough for you to have a conversation and come to your own opinions. In any event, it's been my pleasure to present this data, and I thank you very much for being here.